We're missing something, aren't we? Are we missing something? No, we're doing a live show.
Oh, no.
It's a show, people. That means you have to have showmanship. Sorry, I almost forgot.
Yeah.
Sorry about that.
I feel more comfortable now.
There's yours. So please make sure you get a picture of Casey in his fabulous sequenced outfit. Work it. Oh, beautiful, isn't it? You just feel like you're better, don't you?
Sparkly.
Sparkly. All right, so let's hit go. Use input wireless microphones. Yes, and I've got signal. Can you give me audio?
Can you hear me, Ken? Can you hear me?
Yeah, but you're going to have to project because I yell.
Okay.
All right.
I'll pretend I'm an American.
American. Okay. All right, so this is how we do the show. Here we go. Welcome to the Skeptics Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is October 3rd, 2025, and I'm your skeptical host, Ken Milne. The title of today's podcast is, It's Just a Minor Stroke. Should we still Lyse? And our guest skeptic is Dr. Casey Parker. He's a rural generalist, evidence-based medicine enthusiast, and ultrasound nerd. Welcome to the SGEM, Casey.
Ken, it's awesome to have you here. Thanks for putting on the show.
Well, you're not projecting like an American yet.
Sorry, I got to say it louder. Thanks for having me on the show again, Ken.
You're welcome. And, we should mention, we are doing this live at a conference. So please tell us what the conference is and where we are.
All right, we're in Broome, Ken, my hometown, which is amazing. And the conference is the Spring Seminars in Emergency Medicine, which is one of my favorite conferences. It's the most chilled back, laid back, vibey conference you'll ever go to. And I think you've really been enjoying the town. How's it been?
It's been great. We did a helicopter ride yesterday. They had no doors on the helicopter. I don't know if my wife arranged that on purpose, but there was no doors on the helicopter. We flew up and down the coast. Beautiful, beautiful scenery. And then we went to a pearl farm. They farm pearls. I come from a different kind of farm, an apple orchard, but they're actually farming pearls. And we did actually farm or retrieve a pearl, and it was pretty incredible. Today, we're booked to go to a crocodile show. And then this evening, as one would do in Australia, is we're going to go on a camel ride at sunset.
Perfect.
Oh, very Broomish, isn't it? I have learned about broom time, it's broom time, whatever, broom time. I've also, you said it was very chilled. The first day I presented, I had to wear trousers because my wife Barb is here with me, and she goes, "You're the speaker, Ken, you have to wear trousers." And Casey's out there in cargo pants, shorts and stuff like that. And I'm like, oh.
Shoes are optional, Ken. Shoes are optional.
And so today I've got my shorts on and sandals. But let's give the case scenario that we're going to base this podcast on.
All right, Ken. So Danny is a recently retired emergency department doctor who has spent the last year of his retirement traveling the world, playing banjo and sharing a lot of time with his friends and families. Now, this morning, while he was eating his green eggs and ham for breakfast, Danny felt a sudden onset of right-handed weakness and difficulty speaking. Danny's family were very worried about him. Her. We don't want to de-identify Danny. And they called 000, and she is taken to the emergency department straight away. She gets there within 1 hour of the onset of symptoms. And on arrival at your small rural ED, you do a quick assessment by the stroke team, aka you.
Yes.
And you notice that there is some mild motor right-sided weakness in the hand and a little dysarthria. You've got out your app because, none of us can remember these things. And the NIHSS score is 4. And you order a rapid CT and a CTA, which is reported amazingly immediately as showing no large visual occlusion, no bleed, no tumor, no established cortical infarction. So you look at that and you think many centers I know, and especially in the city, are doing this TPA for stroke. And you wonder, should Danny get a dose?
Should Danny get a dose of a lytic to treat this, what we assume is an acute stroke with an NIHSS score of 4, which is considered a minor stroke. And I'll translate this for the international audience. The 000 would be our 911.
Correct.
And the UK is at 999. Is that It is. I'm getting nods from the audience. Our expert UK person, Dr. Natalie May, and after last night, I was referred to as Dr. May Not. And so let's talk about minor ischemic strokes, or strokes that have an NIHSS score of less than or equal to 5. They're common. Roughly half of all ischemic strokes presenting are with mild deficits. And despite the mild presentation, some of these strokes are not always benign. So there's a difference between, not every mild stroke is the same as another mild stroke. And so about 30% of these patients with an initial minor stroke symptoms end up with significant disabilities, and they can be an inability to walk independently at 90 days. And in short, a small stroke can still have a big impact on somebody's life. And so what should we do? Should we be treating them with a lytic?
Yep. Now, Ken, there's been absolute buckets load of ink spilled over the discussion of the stroke literature, and there's been a lot of debate on this very podcast. So you can go back and listen to episodes 70, 85, 97. I think there's about a dozen. And these are all about the relative risks and benefits of IV thrombolytic therapy for acute stroke. Now, Ken, yourself and Dr. Danny Fatovich, who's sitting just over there, you've earned yourselves the title of non-expert EM contrarians within the neurology literature. And you've even got special red T-shirts, I understand, that you wear with pride.
Yes, when the neurologist called us out at an international stroke conference with a slide that wanted to reassure the neurologic audience of neurologists that despite what non-expert EM contrarians, Dr. Daniel Fatovich and Dr. Ken Milne said, Lyse works for acute ischemic stroke. And so I, of course, took that and made T-shirts. All right, so IV thrombolysis, or TPA, sometimes it's called alteplase, depending on your brand names. We're seeing people move to tenecteplase, or TNK. It has been well established probably for about 30 years now, but based on some questionable evidence. And I think all evidence is reasonable to question, so it's not throwing rocks at this just one topic. However, the role in mild strokes has been hotly debated. On one hand, if it's working, treating it might prevent a minor stroke from evolving into a disability of some kind. On the other hand, TPA, if we give someone a thrombolytic, what are we pretty sure about? It increases their risk of bleeding, and specifically an intracranial hemorrhage that could be symptomatic or even death. Now, guidelines have wrestled with this nuance about what do we do with minor ischemic strokes, and current recommendations endorse using TPA for mild strokes, but they have to have a clear disabling deficit. All right, it has to be a clear disabling deficit. So there's some subjectivity in there, I suspect, but advise against doing it if it's mild, non-disabling a stroke. And the core controversy is whether the potential functional benefits that could be achieved with lysing these patients is worth the increased potential harm.
Now, Ken, things changed quite a lot about 10 years ago with the Mr. Clean trial. When that was published, it showed that endovascular interventions, so clot retrieval techniques, for acute large vessel occlusion strokes could have pretty impressive results, and they had an NNT of around 7, which is a lot better than anything we've seen from thrombolytics.
A single digit. When I see a single digit for an NNT, I'm usually too good to be true. And I'm wondering about what was the numerator and what was the denominator in that equation. But anyways.
Yeah. The role of IV thrombolytics for minor strokes, though, still remains very controversial. Now, a friend of ours, the legendary Dr. Joe Lex, who's a now retired emergency physician, I think gave the best one-liner ever. He said, "If I can kick that syringe out of your hand, don't give me the TPA." Now,
so he was speaking from a patient's perspective, right? Not as the physician. If the neurologist can't kick it out of my hand, you can kick it out of the neurologist's hand. But he was, as a patient, if he's well enough to hold, if I can kick the syringe out of the neurologist's hand, I don't need TPA.
That's right. Yeah. So the question is Joe right?
Right? And he's considered the godfather of FOMED, a free open access to medical education. So he's one of the founding individuals of that movement. All right. So before 2019, practice varied widely. Some neurologists treated almost every stroke. You've got a stroke within the window, Time is brain was the mantra, even for mild deficits, and others were more conservative. Okay, so there was a spectrum on the approach, from some people being more aggressive with thrombolysing these mild strokes, with others being more conservative. Observational studies. We know that observational studies, we can't conclude causation, only correlation. And so they yielded mixed results. And several studies had suggested that thrombolysis in mild strokes improved the chance of excellent outcome at discharge at 90 days, while others showed minimal benefit.
And then we had the PRISMS trial that was published in 2018.
Prisms.
And this was the key randomized study in this area. And it compared alteplase versus aspirin in patients with mild, non-disabling strokes and an NIHSS score of less than 5. And the PRISMS
Less
found...
than or equal to
or
5.
equal to
I
5, I
like to
should
be
say.
less than or equal
5
to
is the
5.
best number, Ken.
5. Why did they pick 5? They probably talked to me.
Yes. And the PRISMS data found no difference in the 90-day functional outcomes of patients, so their modified Rankin score of 0 to 1, so very good functional outcomes, between the TPA and the aspirin group. And they did find an increase in symptomatic intracranial hemorrhages with TPA, as we've already discussed.
So they couldn't identify or report a statistical benefit, but there was an increase in intracranial bleeds, symptomatic intracranial bleeds. We're not going to do a whole critical appraisal of that study, but they did stop early, and I think that's an important thing to talk about. They had originally planned to have almost 1,000 patients, 948, and they stopped the trial early at 313 patients. And they said they stopped the trial because they ran out of money. I'm sorry, that was just a dramatic pause for you to fill the space with whatever you think. This drug company ran out of money for their lytic study. But stopping trials early have problems, and we've discussed this on previous episodes of the SGEM. Because they stopped PRISMS early, they lack the power to definitively settle the question. So by stopping early, the question still remained open about lysing minor non-disabling strokes. And so equipoise remained. And actually, practice often followed the guideline nuance of treating minor but disabling strokes, while generally avoiding TPA if you had a trivial or rapidly improving strokes. And on that slide are 3 different references that talk about the dangers or limitations or concerns that we have about stopping trials early.
All right.
So, what's the clinical question we're going to try to answer on today's episode of the SGEM in Broome, Australia?
So the question is, can in adults with minor acute ischemic strokes, so generally NIHSS score less than or equal to 5, yay, does IV thrombolytic therapy improve functional outcomes compared with non-thrombolytic standard care?
And what do we have to try to answer that question?
So we're going to be looking at a paper by Doheim et al. And it's a meta-analysis of randomized trials on IV thrombolysis in patients with minor acute ischemic strokes. And that was in Neurology this year.
Yeah, this is hot off the press. This is really, really recent. All right, so let's run through the PICO, which we learned about earlier. What was the population that they included in the study?
So they were all adults of 18 that had minor ischemic strokes, so that NIHSS of less than 6.
Oh, that's another way to say it.
Yeah.
See how he's like, ooh, you're getting good at this.
And they were eligible to receive IV thrombolytic therapy within 12 hours of the onset of symptoms.
Yeah, and then they excluded any non-randomized trials, so not observational studies or those without a control arm. Trials included patients with non-disabling strokes, so they had to have something, and in some RCTs, and then mild disabling symptoms. What was the intervention?
So there was a variety of different IV thrombolytic agents. There was alteplase, tenecteplase, and pro-urokinase, and these were given with varying time windows, but pretty much all of them were 3 to 4.5 hours.
And for the American audience, it is FDA approved, for whatever that means. If something is FDA approved, the only thing you can conclude is it's FDA approved. That doesn't mean it works. It doesn't mean it doesn't work. It means it's gone through the FDA approval and it's been approved. And it's only been approved for up to 3 hours. And yet it's a level A recommendation for the stroke guidelines of the United States for up to 4.5 hours. And yet it's not FDA approved for that. So it's used off-label. What was the comparator group?
So the non-thrombolytic standard care group, they could include all sorts of things. There was dual antiplatelets or single aspirin, anticoagulants, statins, antihypertensives, glucose control, all those usual things that we do for people having strokes.
And what was the outcome, the primary outcome? What were they primarily after in this study?
So they were after an excellent functional neurological outcome at the 90-day mark, and that was defined as a modified Rankin score of 0 or 1.
0 to 1. And it's really important to look at stroke studies and see what their outcome was, because sometimes they'll do 0 to 1, sometimes they'll do 0 to 3. In traumatic bleeds and stuff like that for hemorrhagic strokes, they use 0 to 3 for good neurologic outcomes. So you've got to make sure you're comparing apples to apples. Did they have any secondary outcomes?
Yeah, they had a few. So there was the favorable outcome, a modified Rankin score of 0 up to 2 at the 90-day mark. There was also the 90-day mortality, recurrent ischemic or hemorrhagic strokes, and the safety secondary outcomes were primarily intracranial hemorrhage or symptomatic intracranial hemorrhages, SICH.
Yeah, 6. Yeah, I guess you could have said intracranial hemorrhage, and they dichotomized those into symptomatic and not symptomatic and kept it at 5.
Yep.
But the see, people can't pick up that glance in a podcast. It's like, really? But what's more important? I don't think patients really care if they bled into their brain if they never knew it, and it wasn't on an imaging study or a radiologic outcome. So what type of study was this?
So this is a systematic review and meta-analysis of randomized controlled trials.
Exactly. All right. So next part of the critical appraisal is to give the actual author's results. So I Googled this guy and found a picture of him. So I think it's very a nice picture of him. And I'll read it exactly from his group's conclusions from the abstract. Quote, IV thrombolysis does not confer improved functional outcome among patients with minor strokes and can be associated with higher odds of symptomatic intracranial hemorrhage and mortality. All right, so that's what they concluded. Let's go through the quality checklist. We're going to go bang through these quickly. So this is the quality checklist that you can get from the Center for Evidence-Based Medicine, and they have a variety of different checklists. The first question is, do you think that the question they were asking was both sensible and answerable?
Yes, it was, Ken.
Do you think that the search strategy to look, remember we talked about search strategy, was it detailed and exhaustive?
It was, Ken. They searched PubMed, clinicaltrials.gov, the Cochrane Library, the Web of Science from 1995 up to the current date, and they reference checked all those people and looked at the trial registry.
Yeah, they went through all the references in those original studies and just, it was detailed and exhaustive. Do you think that the primary studies that they included, to avoid GIGO, do you think the studies that they included in their systematic review had high methodologic quality?
Yeah, I think mostly they were. The randomized controlled trials were assessed using the ROB2 process.
ROB stands for risk of bias. ROB2, risk of bias, and it's their second iteration, and it's out of Cochrane.
Okay. And overall, that rated the risk of bias as relatively low risk, although there was some post hoc and subgroup analyses that happened in some of the trials where there were a little bit of concerns about completeness and maybe some baseline imbalance between the two groups.
And how they assessed the trials, was it reproducible? Right? Could you do this?
Yeah, it was. So they had dual independent screening and data extraction with adjudication, and they followed a very rigorous process for that. So yes, I think it was.
And here's one of my favorite questions. Was the outcome clinically relevant?
Yes. The modified Rankin score is a moo. So we love poo.
No,
sorry.
it's a poo.
It's a poo. Sorry,
it's a poo.
So modified Rankin score, mortality, the 6, so the symptomatic intracranial hemorrhages are all things that we care about. They're poos.
Yeah, so a modified Rankin score goes from 0 to 6, with 6 being dead and 0 being no deficit. A 1 is mild, and sometimes it can be really hard, of course, to determine who has a mild stroke and who has a slightly worse stroke, so that fuzziness is usually around determining if they're a 1 or a 2. Most of us can pretty much figure out they're fine and they're dead. The nuance comes in between, all right? And so, that's really important to patients. What's my function? And then did I have a symptomatic bleed? And am I alive or dead? How about, okay, we got to do some statistics. How about the statistical heterogeneity? That's called the I-squared test, and that's how we monitor or quantify how similar the studies were.
This one I'm a little bit unsure on, Ken. It's a bit fuzzy, as
It's
you
a bit
say.
fuzzy.
Bit fuzzy. So the authors assessed the heterogeneity using the Q score and the I-squared score, and they performed a thing called a leave one out analysis. That's basically where they look at the RCTs and then
kick one out.
they do it with the 3 that are left over, and then they kick another one out and do it with the other 3, and they see if it changes the outcomes, which is brilliant. And we couldn't really find a citation in the main text that looked at the actual I-squared score, and or the Q score, but because it's such a small number of studies, the I-squared score is not going to give you a lot of precision in this context. So the authors did note that, and they did note that when they did the leave one out test, it didn't change anything.
All right. So was the treatment effect, the magnitude of the treatment, was it large enough and precise enough to be clinically significant? I love doing funny voices.
I'm sorry, Ken. That's a no. So there was no benefit found. The primary outcomes.
We'll get to the actual numbers, yeah. All right, so hey, where'd the money come from? Who funded this? Because that's an important thing to consider. Not that conflicts of interest invalidate or automatically negate studies. They don't. But they should make us more skeptical based on the evidence that is presented on conflicts of interest.
Yep. So the authors of this particular paper had no funding to report.
But what about the original studies? Did the original studies have some funding issues or conflicts of interest to declare?
Yeah, so that's where it gets a bit gnarly, because all of these stroke trials are, of course, sponsored by the drug companies that make these drugs. So most of them do have that conflict of interest and potential bias.
Yeah, and it's always a potential. It doesn't negate. All right, so hey, they've been waiting. What were the results? Well, they had 4 randomized control trials they could find. Only 4 on minor non-disabling strokes and an NIH score of less than or equal to 5. They got over 3,300 patients into the study. They were, calling someone middle-aged or old changes as my birth date changes. Because when I started medicine at age 30, anybody under 30 was young, anybody over 30 was old. Now at 58, I'm in this old group now. They were 56 to about 80 at the baseline. And that NIHSS score was about anywhere between 2 to 4, so less than or equal to 5, as they had in their inclusion criteria. But let's drill down into some specific numbers. Key result.
The key result. So compared to non-thrombolytic standard care, IV thrombolysis did not improve excellent 90-day functional outcomes, that modified Rankin score of 0 to 1, and was associated with a higher odds of symptomatic intracranial hemorrhage and mortality.
So not much potential benefit, at least not statistically different, but you did have a potential harm of a symptomatic bleed or increased mortality. Now, we don't want to get too much into the weeds, so we'll just give the number for the primary outcome. What was the odds ratio for that primary outcome?
So the odds ratio of having a favorable neurological outcome was 0.85. Sorry, Anand, I know you don't like decimal places, but 0.85. And the confidence interval went from 0.7 up to 1.03.
And so what that is saying is that it spans the number 1. And if you are a Bayesian, like our friend up front, that doesn't mean it doesn't work. It just means on this frequentist model average, it crosses 1. So we give this it wasn't statistically different. Now, when it came to the second outcomes, you said there were a number of them. I think you gave 6, but did you see that I made 5? Yeah. So for a modified Rankin score of 0 to 2, better?
No difference.
Actually, it was worse.
Oh, yeah, it was. That's
worse
exactly right.
With intravenous thrombolysis.
That's true.
How about symptomatic intracranial hemorrhage? Better, worse, or the same?
Worse.
How about any intracranial hemorrhage?
It was also worse.
How about mortality?
That was also worse.
Ask your doctor if thrombolysis is right for you. And how about recurrent? How about recurrent stroke?
So there was no difference in recurrence of stroke, and that's not sort of something I would expect from a thrombolytic.
Yeah. All right. So my favorite part of the whole process, I get to talk nerdy to Casey. Nerdy. Oh, talk nerdy to me. Oh, yeah. Okay, so we're going to go through how many? 5. Thank you. Oh, my goodness. Okay, so you have the first one.
Okay, so the first nerdy point, Ken, is what goes into the sICH machine. So this is a big meta-analysis including a range of trials with different inclusion, different exclusion criteria, differing baselines. The geography was very different. Some were in China, some were in different countries, and the demographics are different. And the standard care comparators were also different. So there was dual antiplatelets, aspirin. So it's a bit of a fruit salad of evidence when you
Oh,
put all
fruit
that.
salad instead of a sausage.
Yeah, well, I like my metaphors.
Yes, okay.
Food metaphors. It can be hard to know how this data applies to the patient that's sitting right in front of us or our population, given that this comes from a whole different range of backgrounds. So to make that decision, you really need to go back and look at the individual primary trials and see if they represent the population that you're treating in your emergency department.
And I am a rural emergency physician, so I like to bring in rural aspects to when we're critically appraising the research. So this is about rural stroke application. In large tertiary hospitals where access to immediate imaging, stroke teams. I love it when you said, yeah, they called the stroke team me. And there's that famous thing, there's no I in the word team. Oh, there is when you're in a rural hospital.
Yep.
There is I in the word team
Yep.
because I'm all you're getting usually. I don't want to, the nurses are fabulous. Everybody else, it's team. But yeah, but the stroke team, yeah.
Yep.
And they've got clot retrieval for these large vessel occlusions and all those types of things. That's available in a large hospital. In rural or community hospitals, we don't have as much information. We may not have access to these different diagnostic studies and these techniques that they can actually do something. These large vessel occlusions, the data is much stronger for that than it is for thrombolytics. And so we run the risk of always thinking, oh, we're just second-class citizens living in a rural area. We're going to get postal code medicine. Your care will be based on your postal code, not on your need. But you know what? This trial gives some clarification about, should I be thrombolysing these people in these smaller communities, or do I have to ship them out? And it would suggest that we do not need to ship these people out. We could make them worse by thrombolysing them. There may be not an upside to thrombolysing them. And so we can take great care of these patients closest to home in their own community. So I like that.
All right, number 3, Ken. The point of this is you cannot fix asymptomatic, but you can certainly make it worse. So this study largely consists of patients with non-disabling stroke symptoms. So these are patients who may or may not turn out to have
Dr. May, calling Dr. May, paging Dr. May.
may not turn out to have an actual neurological deficit after their initial treatment window. It's probably expecting a lot from a single drug to fix someone with a modified Rankin or an NIHSS score of 1 or 2, because that's not how these drugs work. And so we can certainly look at the risk and benefit here. And we know that there's very marginal gains on the benefit side, but we definitely know from this trial that there's a potential big downside to this.
Yeah, giving lytics, I'm much more confident in the potential harms than I am of the potential benefits. I think we have more data that when you give someone a lytic, they're more likely to bleed than if they get a placebo. And then this gets back to the point that not all minor strokes are minor. We define it using this scale, this NIHSS scale, less than or equal to 5, but this is not a uniform group of patients. You can get a low score and have a facial droop or vertigo or motor loss of the left hand. And, if you're left-handed, that's more important than somebody who's right-handed. So it all depends, right? And so we really have to look at one of the core aspects of evidence-based medicine and talk to the patients about what they value and what they prefer, right? So if that deficit is like, yeah, whatever, great. But if what we might consider a minor disabling deficit is devastating to them, that's important to them. And it's about them, not about us as the clinician. And so this is going to be very difficult to do, though, and certainly can be difficult to call off, once you pull the trigger, code stroke, and that inertia to do stuff, that pressure to intervene, that intervention bias can become overwhelming. However, in the light of this data, are we simply rushing to provide a drug that's going to increase their potential harm and make them worse? So I think we should really rethink about our system of stroke call. And I apply this to all of these code strokes, code STEMIs, code sepsis, code paronychia. Because I can guarantee if you call a code paronychia, time to first physician contact will improve, time to antibiotics will improve, time to discharge will improve, and patient satisfaction scores will go up. If you throw resources at it, right, you get those metrics. But I think that we still need to pause and slow down just a bit. A few minutes is all it takes to reflect and think, is this the right way forward for this patient? And talk to them and take the time to do that.
All right, point number 5, Ken, is about the primary papers and the biases within. So all of these trials pretty much were funded by pharmaceutical companies, and we know that there are biases that creep in the data when there's money involved. So, and especially when there's no blinding involved. So this is a big problem. And although the modified Rankin score does seem like a really objective outcome on paper, the way that they collect that data is not entirely objective, in that some of them are just phone follow-ups or patients self-reporting, and the patient knows which therapy they got if it's not blinded. So it's not entirely objective. So the fact that these biases should really be pushing the data in the direction of benefit for the drug, and we didn't find a benefit, that makes this data even more robust.
Yeah, doesn't that strengthen your confidence in it? Because there was one of the trials that was done, not necessarily in this one, but where they did thrombolysis and stroke, and they did telephone interviews with the patients or their family members, and their patients and their family members knew that they either got this lytic that was supposed to improve their function or didn't. And then they asked them how they were doing on the telephone call. What do you think you would report if you knew that you were in the treatment group? Or what would you report? Which direction would the bias be if you were in the placebo group? 90 days out, how are you doing? Yeah, not very well. They were in the placebo group. You can see how that bias would push you around. And so because they didn't find benefit, which is what you were pointing out, because they didn't find a statistical difference, that makes me believe the data even more, because the direction of bias should have been to find something positive. All right, so SGEM Bottom Line. Let's wrap this up.
Yeah, so Ken, we agree with the author's conclusions, but would probably state more explicitly for ED care, we should not be giving or offering intravenous thrombolytics to patients with non-disabling minor strokes.
Routinely, right? Yeah, and so for minor non-disabling strokes, IV thrombolysis has no demonstrated proven functional benefit and does increase the risk of symptomatic intracranial hemorrhage and mortality compared to people who don't get it.
Cool.
Can you resolve that case? It was Danny or Denny?
Danny.
You guys have nicknames for everybody. I met a Jono last night, right? And you got to throw an O on the end of every name.
Let's go Keno.
Keno. Oh, I'd love if I left with a cool nickname.
Well, actually, Ken, there's a famous Australian character called Kenny, who's a mobile toilet operator. So we'll give you that one.
And it fits with my poo, do, and loo.
There we go. So after reviewing the CT, and we've gone back to the bedside and chatted to Danny again, you discussed the relative risks and benefits of IV thrombolytic therapy compared to standard care with antiplatelet drugs in early rehab. Specifically, he discussed the risk of potentially making things worse, and we say that there's roughly a 5-fold risk of symptomatic intracranial hemorrhage and roughly a doubling of your chance of being dead at the 90-day mark. This is weighed against a very small potential benefit for Danny for his mild symptoms, which may or may not have a disabling impact on Danny's lifestyle and function in the future. After this discussion, Danny decides that he doesn't want to have IV thrombolytic therapy, and is referred to a wonderful local stroke rehab ward for early physical and occupational and speech therapy.
And there's some really good evidence on the number needed to treat with good stroke rehab for causing a benefit, as opposed to lytics. And we've gotten away from, can we just give this flushing out the drains and the pipes, and laying hands and working with patients can actually have a very good therapeutic outcome. All right, so how are you going to take this new study and apply it clinically in Broome or Western Australia or other parts of Australia?
Well, I think for patients with minor non-disabling deficits, this systematic review and meta-analysis supports withholding IVT and using evidence-based standard care such as dual antiplatelets and other care like we've just discussed. After imaging to exclude, obviously, hemorrhage and assessing for large vessel occlusions, which may actually have a better treatment option. if the symptoms are mildly disabling, the evidence remains uncertain. We suggest engaging the patient in a shared decision making and considering them enrolling in a new clinical trial to investigate for mild disabling strokes or expert consultation at that point, balancing the potential harms such as bleeding and mortality against unproven functional clinical benefit.
And so then finally, we always need to sit down with the patient and try to translate this into English, Australian, or American.
Mm. So,
Separated by a common language.
so I'll sit with Danny and his family and we'll say, we don't know if there's a clear benefit to IV TPA in patients with minor strokes such as what you've experienced. The relative benefit of IV TPA is dependent on the impact that the stroke and the symptoms will have on your lifestyle. We don't know if we do know that there's a risk of increased intracranial bleeding with worsening functional neurological outcomes and a small increase in mortality with this therapy. However, we also know that good medical therapy and physical therapy can lead to excellent functional neurological outcomes in people such as yourself.
I really like that. Really engaging with the patient, empowering the patient, and giving them some agency and autonomy in a shared decision-making process. Because while you may be an expert at the data and the clinical aspect, the patient has their own expertise. They're an expert at their own personal journey and what they value. And we need to put our expertise together, and so we can have the best outcomes. Well, that brings us to the Keener contest. And for those not familiar, every episode of the SGEM that we do a structured critical appraisal has a trivia question at the end. We call it in Canada a Keener contest. In the States, they call it a Gunner contest. And so last week's winner was Dr. Cindy Bitter from St. Louis, and she knew that the 988 number is the Suicide and Crisis Lifeline that is administered by the Substance Abuse and Mental Health Services Administration, which is part of NIHSS and was launched in 2022. Casey, we need a really local Broome Keener contest question. Don't shout out the answers because we want people to listen to the podcast. And then whoever sends me an email to the sgem@gmail.com with Keener in the subject line, that first person who responds, not you people, because you probably know the answer. I didn't until Casey sent this to me. I will give them a shout out on the next episode. So what's the Keener contest question?
All right, Ken. So since we're sitting on the wonderful, iconic Cable Beach in Broome, Western Australia, I want to know, why is this beach named Cable Beach?
See, you know the answer, don't you? Yeah. Yeah. But if you don't know the answer, if you do know the answer, sorry, then send me an email.
Yeah.
Right. The sgem@gmail.com with Keener in the subject line. All right. One final thing after thanking, and don't you think Casey did a great job? I wearing a sequence jacket and a sparkly jacket and stuff like that just gives you confidence, and it also radiates off any sweat or anxiety or anything like that. But thank you very much. And this is my opportunity to also thank the conference organizers. We have had a wonderful trip here, Barb and I. I will say this with my tongue firmly in my cheek, the warm welcome to the Canadians. But we've absolutely had a wonderful time because of you. And so thank you very much for inviting me to come. It was wonderful. I really appreciate it. Casey, you need to read the SGEM tagline.
I will, Ken. Remember, people, to be skeptical of anything you learn, even if you hear it on the Skeptics Guide to Emergency Medicine.
It's now break time. Well done.